Hello students, my name is Moon and this is the EMT program at Queensborough Community College, He200. And this video is for lecture for Chapter 18 of our textbook. So a week ago, a little bit over a week ago, I told you don't come to class for this day because it's a holiday schedule. So you can go to assignments, you can go to announcements, and then I told you this a week ago in class, and here I am reminding you today by announcements that do not come to class, do not come to campus. The lecture will be hosted on video, which is what you're watching right now. Oh, by the way, don't pay attention to the dates or the section numbers or anything like that, the years, because this video will be reused in the future. So anyway, as usual per our lectures, you can download the slides for yourself. You go to the bright space for EMT where it says red letters laboratory, and you go to that bright space page, and then you go to click on modified lectures, part 1. Scroll down until you see Chapter 18, which is the lecture for today, Cardiac Emergencies. Then you'll be able to download the slides, and you should see this in front of you. Download the slides so you can watch along, if you have some kind of text editor, you can make notes as you go, or if you're a boomer like me, you can use pen and paper to make notes like you go. Alright, so yes, it does say 135 slides, but the last dozen slides or so is review, recap, which I'm not going to cover because that's what the whole video is for. And the first few slides are preamble or like a table of contents. So let's go to the real meat of the slideshow. And now let's get started. This actual first slide, slide number 5, should not be anything new because we went through all of this in the A&P, Anatomy and Physiology lecture, Chapter 6. So I'm not going to restate all of this for you, but pause here and then watch, pause here and go back to your notes for Chapter 6. You can also click on, go to this slide, number 5 of the slideshow, and then follow the link here to the YouTube video, which is a very nice overview of what I just talked through. So maybe the people here on this video explains this concept in a different way than the way I explained it in lecture so many weeks ago. So you may find that useful. So blood goes round and round. The heart is the pump that makes it go. The vessels are the tubes that the fluid flows through, and blood is the fluid itself. If not enough blood is reaching every cell of the body, then that's hypoperfusion, which in the short slang is what we call shock. If you check Google image or your favorite browser for a diagram of the heart, you get a very busy diagram typically. And let's see, this. Yep, you have to know all these words. These words came up, these vocabulary terms came up in Chapter 6 Anatomy, so you should know it by now. But now that we are in the cardiac emergencies, you absolutely must know it. So this is what you can do. And remember the trick I showed you where you go on the if you're working from a desktop, either from home or the computer lab, then you can do screen capture, whatever the button is for screen capture, which is print screen, and then bring up your favorite image browser, you paste into there, and then you select this area here, where the busy work is happening, crop it out, and then use your whatever editor and go through and delete the texts. And what do you know? You've made yourself a little quiz app all yourself. It's totally free. You're not allowed to sell it, but at least you now have a way to test yourself, be able to label every one of these lines. But now that I have my favorite image editor up, it brings me to the point where back in chapter 6, when I went through the anatomy of the heart, I said that for the introductory student, that diagram you just saw was very, very busy. There was a lot of information, a lot of new concepts coming to you all at once, and it may have been difficult to follow. So what I told you was, let's start very simple here, and let's just draw ourselves a heart the way we remember it here. So here is the heart as poets and philosophers like to think about. But then let's draw two lines, one horizontal, one vertical. You know, the image is not to scale. It's oversimplified, not that accurate anatomically, but it's good enough for our needs. So we have the four chambers of the heart. This is the, let me change font. This is the atria, and then at the top, and then we have the ventricles at the bottom. And then remember, this is the right side. It's always the patient's right and the patient's left. So the right atrium, right ventricle, left ventricle. We have these gaps here, and that will be the passageway from the atria to the ventricle. Remember that they have valves here. I won't take the time to label the valves, but we did go through them before, right? Well, maybe I should. So let's go draw in some valves. So we have this valve going through here, and then we have this valve. But remember, on the right side, it's 3 leaves, so it's a tricuspid valve. Here's a bicuspid valve. Anyway, let's follow this pattern now. From the left ventricle, we have the, that's going to be, this again, this is not anatomically correct to scale, but it's good enough for us. So blood leaves the left ventricle through the largest artery of the body, which is the aorta, and then the aorta divides into arteries, and these arteries divide into smaller arteries until we get to the tiniest arteries of them all, which is the arteriole. And I'm going to change color now to some random color, and the arteriole feeds into the single cell wall thick vessel, which is the capillary. From the capillary, it feeds where the gas exchange happens between the blood vessels and the cell, and this is the only place it happens, in the capillaries. It now is deoxygenated. It's dropped off the oxygen. It's carrying now carbon dioxide into the tiniest of these, which are the venules, which join together with other venules and form veins, and then the veins join together into bigger veins, and then these bigger veins join together to the largest vein of them all, which is the vena cava. Here's the inferior vena cava, here's a superior vena cava entering into the right atrium. From there, blood, which is still deoxygenated, falls through to the right ventricle through the tricuspid valve, and then out the pulmonary artery. And this is point of trivia, this is the only artery that's deoxygenated because it's heading out to the lungs, where it will drop off the carbon dioxide, pick up the oxygen from the body, from the lungs, and then it'll make its way through the pulmonary vein, which correspondingly is the only vein that is oxygenated. The pulmonary vein is the only vein that is oxygenated. It's called a vein because any vessel that heads towards the heart is called a vein. Any vessel that heads away from the heart is called an artery. And here is the circuit. There's 2 circuits. There's the systemic circuit, which is, I better spell that because we want to be absolutely clear here. This is the systemic circuit, not systematic. Don't make that mistake. This is the systemic circuit, and then here, up here, is the pulmonary circuit, not including the aorta. Let's not include the aorta in this pulmonary circuit. And there are 2 loops then. Okay, but you knew that because we did this whole thing in chapter 6. I told you that the sooner you can draw this from memory, the better off you are. And by now we're here in the cardiac emergencies chapter, and now you must know this flow by memory. You've already experienced one test question where it said something like, you are here, whoops, switch pens, you are here, where are you supposed to go next? You have that type of a question, or the other type of question where it asks you, which of the following choices have the different parts of the circulatory system in the correct order? So there'll be these random names, and you had to pick which one was made sense in the flow of blood through the system. You really need to have memorized this list, the sequence, by the midterm, because there'll be more questions just like it. So, and now let's say you feel like, oh, come on, I'm not good at drawing, or your method of learning is not visual, you're much more of an auditory learner or kinesthetic learner. Well, then don't bother with the drawing. It helps, but it's not mandatory. Instead, you can just get rid of all this and then just start typing out the things you need to say. So you can take out a pen and paper or your favorite text editor and just start going through aorta and then artery and then arterioles to capillaries to venules to veins to vena cava, etc., right? And then there's also then the sequence of blood flow through the heart, which is the from the vena cava to the right atrium through the tricuspid valve. Let me make the font smaller so the whole thing will fit. To the right ventricle, out to the pulmonary artery. Actually, there's one more valve here, pulmonary valve. One of these valves, it stops the blood from going backwards. And so it's pulmonary artery to the lungs, where you get the pulmonary capillaries. And then on the way back to the heart, you have the pulmonary veins to the left atrium. Running out of space already. Through the bicuspid valve into the left ventricle, and then can I do it? Nope, I gotta shrink it one more time. Hopefully you're able to still see this. And then this time out the aortic valve, and then you're finally out into the aorta, which takes you back to here. Like that. And from here, you can go here, like that. So you can draw, if you're not that confident or you're self-conscious about your drawing abilities, you can spell it out like this. It's okay. This is not Pictionary where letters are not allowed. You're allowed to draw as many letters as you want. But be able to reproduce this sequence on command through memorization. Okay, you know what? That's enough warning to the wise. I don't know how to emphasize this anymore. You must memorize this. And now I'm going to save my breath. If you still refuse to, I don't know what to tell you. but you must memorize this by the midterm. And so we're back to the slideshow, and this is a anatomically correct diagram of everything we just drew as if it was in crayon. The next picture is more emphasis on the flow of blood through the heart. And now that you're good at drawing or spelling out the sequence of the parts, you can now make sense of a diagram as complicated as this. Let's see, this, yep. You have to know every word. You have to learn every word on this diagram. This is in your textbook, so either cover the words with a post-it note, or do the copy paste into clip art thing that I showed you before, but start studying. Okay, how does the normal function of the heart and blood vessels relate to blood pressure and distal pulses? Heart is the pump. It generates the systolic pressure. The tension or the backwards flow or resistance of the blood vessels to the flow of the heart is the diastolic pressure. And if both two pressures are not high enough, then not enough blood flow is bringing precious oxygen, sugar, and other vital nutrients to our cells, or taking away the waste products, and we say that the person is in shock. Everything I said up to this point, the previous point, was review. And now here's something new. Your heart is made up of millions and millions of cardiac muscle cells. They all have to contract together in synchronization in order for the whole thing to work. And my favorite analogy for that, I hope this is for educational purposes, I hope the owners of these images don't sue me, but my favorite analogy for that are these ancient large sailing or rowing vessels where they have like hundreds and thousands or even thousands of employees, sailors, who each one grabs an oar and starts rowing at the same time. They all have to row in synchronization in order for the boat to make any kind of progress. Otherwise, if they all row at any speed or range of motion that they feel like, then the boat is just going to be stuck in the water, not going anywhere. So the synchronization is critical. How does our heart make sure that every heart muscle cell contracts exactly when it's supposed to? And that is the cardiac conduction system. Conduction as in like electrical signal. This is more of a chemical electrical signal, and the details of how this happens is above the level of the EMT program. What you need to know as an EMT to answer the appropriate questions on the state written exam is that it's some kind of electrical conduction system that flows through the heart and tells every muscle cell when to contract and then after that it's allowed to relax. And the impulses start at the SA node. The SA node here stands for the sinoatrial node. A sinus, if you've ever heard the word sinus before, it's most likely referring to the air pockets in your facial bones. So the sinuses in your facial bones are called that because it's a pocket. A sinus is a fancy technical term for an anatomic pocket. So whoever sliced open the first few hearts and wrote about it said, hey, there's a pocket here in the right atrium. And so it's a pocket, we're calling it a sinus. It's in one of the atriums, so it's sinoatrial. And then later, other very, very smart people who noticed that there's this electrical pathway system in the heart, notice that it's always starting here. Well, in the normal patient with a normal beating heart, the signal seems to start here, and then start working its way down through to the rest of the heart. There is another node. It's kind of like stations on a train system where the signal goes and then stops here, pauses for a little bit, and then continues on. And that's the AV node, or atrioventricular node, meaning that it's between the atria and the ventricles. so the AV node. And that's about it. That's about all you need as an EMT to know. You don't need to know the names of these other structures. For those of you who go into the paramedic program, then you do. Now, if this is electrical, how do we know? Because if we put electrodes around the chest, those stickies with wires that paramedics and above start sticking on your chest and feeds into a machine, and it generates a printout, and the printout looks a little bit like this, then we see electrical activity. It's not the focus of this program, the EMT program, to learn EKG, but here is samples or examples of what an EKG looks like. Maybe your doctor has generated one for you when you went for a checkup. Okay, so for those of you who do go onto a paramedic program, you learn how to interpret these things, because it's a great way of getting a guesstimate of what's going on in the heart, at least electrically. One more term you need to learn as an EMT, and you're expected to know as an EMT, is that when the electrical signal passes into one of the heart cells, it's kind of like when one of these rowers hears the drum, right? In a typical movie that features one of these vessels, there's always some guy either in the front or the back with a giant drum pounding away, and that creates a kind of a rhythm that the rowers can row to. So it's kind of like when one of the rowers hears the drum beat is when the cell receives the electrical impulse and it causes the cell to contract, and that's a muscle. But what if a electrical signal never comes, or it's too slow in coming because there's a little timer, and when the cell does not get a signal after a while, it finally gives up waiting and contracts anyway. That ability of a cardiac muscle to contract anyway if it never gets a signal or not in time is called automaticity. This is very, very useful for sustaining life. You know, your other muscle cells, like your arms, your skeletal voluntary muscles, if you never tell it to move, it will not move, which is a good thing. You don't want your body to start suddenly make some kind of motion that you didn't tell it to do, especially your skeletal muscles. But with the heart, if there's some kind of problem with the conduction system, some kind of heart disease, then you don't want the cells down here to say, hey, I didn't get a signal, so I'm not doing nothing. I'm not going to do anything until the boss tells me to. No, you need them to maintain a pulse. So if they never get a signal because somehow the transmission lines are broken or impaired, then they need to take the initiative and make the heart beat for itself. And that is the automaticity. For those of you who want to learn more, and you don't have to, but if you want to learn more, here is a link to a decent video about the cardiac conduction system. The reason why I chose this one is because if you just went by yourself to YouTube and search for cardiac conduction system, the vast majority of the videos you get out there are way too advanced, too complex for the needs of an EMT. You're going to need like several dozen hours of lecture to explain all the terms they go into. But at least the first half of this video is keeping it simple, approachable. So if you want to learn more, knock yourself out and watch this video. If you're not that interested, or let me put it another way, if you're too busy doing other things, like real life things, like taking care of the home, taking care of the family, bringing in the money, and so you barely have time to study for the EMT class in itself, then don't worry about this slide. There are times when the heartbeat is not regular and strong, which is terms from your vital signs about assessing a pulse. And when the heartbeat is not regularly regular, then that's called a dysrhythmia. What's the difference between a dysrhythmia and an arrhythmia? Arrhythmia is any rhythm that is not regular. But if the arrhythmia is so inadequate for health that it causes like symptoms, then that's a dysrhythmia. Dys is the prefix for bad. A means not. So if you see somebody on the dance floor embarrassing themselves, making a fool out of themselves, just not being inspiring or charismatic, then you can say that guy has no rhythm. Of course, he has a rhythm, but it's not a good rhythm, but not necessarily a bad rhythm. There's just not a very inspiring dancer. So this person has no rhythm, a heart that is not beating regularly, but otherwise it's not doing anything bad, is arrhythmia. But then if the bad rhythm, if the not good rhythm is actually so bad that it's bad, is causing problems, then that's a dysrhythmia. You've heard of Tachy and Brady, too fast, too slow. You've heard of ventricular tachycardia, which means the ventricles by themselves are beating way too fast. You've heard of ventricular fibrillation. And so where have you heard these two terms before? In CPR. Because in the CPR lecture you learned that these two rhythms are the only two that are shockable. If you had somebody with bradycardia, too slow heartbeat, and you put the AED pads on and you just pause for analysis, then it would say no shock advised, because it's not a shockable rhythm. If it's only when the AED detects VTAC or VFib, then it will say shockable. There is one kind of rhythm that everybody knows of, and that's flat line. I know this line doesn't look very flat, but they don't have to be perfectly horizontal, straight, to be considered flat line. Asystole, remember systole? Systole is the contraction of the heart. And when pulses are involved, we mean the left ventricle, right? Because that's where we check the carotid pulse. That the left ventricle contraction is the one that generates the carotid pulse, the radial pulse, all the pulses in the body. If they're not contracting, they're not generating the systole, which is the higher number. Remember, in blood pressure, there's systole and diastole. So if there's no pulse, then there's no systole, and so that's asystole, A meaning not. So that is asystole. Now, if you put electrodes, EKG electrodes on the chest, and you see this line, it means that there is no electrical activity, no detectable electrical activity. This is not shockable because it's not VFib, it's not VTAC, so it's not shockable. And that kind of makes sense, because how does an AED actually help? How does an AED fix this? Well, first of all, AED stands for Automated External Defibrillator. So what is fibrillating that you want to defibrillate? Fibrillating is like when, let's use this analogy, all the rowers of these boats, of a boat, instead of rowing together, they just do their own thing. The captain of the captain of the boat sees each one not rowing together. They're kind of like forming factions and cliques, and they're not communicating. They're doing whatever the hell they want. Some of them are like stopping for a break when they're not allowed to, and the captain keeps yelling at them, "Row together, you scurvy dogs!" And each one says like, "You're not the boss of me," and they're just completely ignoring orders. So none of the oars are working together, and it's like the boat is stuck in the water. If all the cells of the heart do that, then instead of beating together in synchronization, in rhythm, it's just quivering there. It's just sitting there quivering as different parts contract at different times. So we call that fibrillation. The AED then goes through and forces all cells, all the cardiac muscle cells, to contract at the same time. And that means that if all the cells contract at the same time, then they will be forced to relax at the same time, and then the act of relaxing causes the cells to take the same amount of time to pause, recover, and then beat again. So the AED works by stopping an abnormal rhythm, which was the answer in the CPR test. AED helps by stopping an abnormal rhythm, with the hope that once you've stopped it, once you've told every one of the sailors to like stop, everybody stop, put your oars down, stop, and they all finally stop under command, and then through their own initiative, assuming that every one of them needs the same amount of time to row again, then through their own automaticity, that they will start rowing together again. So the AED does not force the heart to have a normal rhythm. It forces the heart to stop all at the same time, and then the heart by itself will restore its own rhythm through its automaticity. What if the heart is in brady or asystole and there's no electrical activity? What that's saying, it's like every one of the sailors here died, or they went unconscious. I don't know. They all had diabetes, and they all went into a diabetic coma, and so no matter what you yelled at them, nothing is happening. The AED then cannot stop a stopped heart. So then that's why asystole is not shockable. Then how come in the movies and the TV, whenever they show this kind of like shocking in a medical setting, they show something like this on the screen, a flat line, and then the doctor puts the pads on and yells clear and shocks the patient, and then you get a heartbeat again. Why is that happening? Because it's a total fiction. It's a movie, it's a TV show, and they know that the general public knows nothing about this. So if you try to show VFib or VTAC, then the audience is going to get confused. They're going to look at each other as they're passing the popcorn, and they're going to say, is that bad? I don't know it. Well, I mean, let's bring one up, right? So let's say ventricular tachycardia. Let's bring up an example of that. So what if we showed this on the screen? Then in the movie theater, then the audience is going to look at each other as like, is that bad? I don't know. The background music is sounding a little ominous or depressing. I guess that means it's bad. It's going to confuse the public. But if you show asystole on the movie screen, and now everybody can agree, yeah, that's bad. This guy's dead. And so that's the whole purpose of that fiction. In reality, we do not shock flatline, and this is why paramedics and above have a hard time watching fictional medical dramas on their off time. That's one of the reasons. The other reason is that most of the time in these fictional medical dramas, the actor puts the stethoscope on backwards. And now that you've learned vital signs, you know the proper direction, the proper way to wear a stethoscope, and now you know not to wear it backwards, I hope. Right, we should be around a little over 30 minutes into this video, and you're supposed to have a lecture for 4 hours. It's that long of a chapter. It's that long of a topic because chest pain, a heart attack, I'm using air quotes now. My camera is on, but imagine me using air quotes. A heart attack is one of the most serious calls of 911 that an EMT can go to. So there's a lot to talk about, and anyway, it's going to be a long lecture. So make sure you, if you don't have a snack and a drink ready, go get one, hit pause, go get one, and when you're all set up, then come back and resume play. By the way, as you're watching this on your video player app, and you think that maybe I'm talking a little too slow, which I think of myself whenever I watch videos that I make, one of the big problems I have listening to my own voice, other than it doesn't sound like what I think I sound like, is that I just talk too slow. Right now, as I'm talking, I think I'm talking as fast as I can, but when on playback, I notice that it's too slow for me to stand. So if you feel the same way about my voice, usually around here on the video playback machine, or maybe it's up here somewhere, there's a settings icon, and then you click on that, and then you can change the playback speed to 1.25 or 1.5 or even 2x if you're that good at understanding what I'm saying, and that should help the evening pass a little faster. So let's get into actual cardiac emergencies. Acute meaning short term of the heart. Syndrome. A syndrome is our technical term for a set of symptoms a set of signs and symptoms that seem to occur around this disease. So it could be as disparate as nausea and weakness and dizziness and confusion, and feelings of doom, as well as narrowing of vision. So there's a lot of different symptoms that the patient will record, and doctors have noticed that whenever somebody is having a coronary condition that's short term, they seem to show up more often together, more often than not. So they decided to put this into a list and say this is acute coronary syndrome. Sometimes called cardiac compromise because it's not a stopped heart. It's not complete heart failure. If it was a stopped heart, then we wouldn't call it acute coronary syndrome. We would call that cardiac arrest. And you know what to do for cardiac arrest, right? You all have your CPR certifications by now, or at least you're eligible for it and the cards are on the way. So the most common reason, not the only reason, but the most common reason is that the muscle cells of the heart, the cardiac muscle cells, are not getting enough oxygen to do their job. This is a huge expenditure of energy. A lot of oxygen is needed to convert all that sugar into ATP so that your cardiac muscles can burn off the ATP to do their contractions, and they cannot stop. A heart that stops is a dead heart. It's a dead person. So it cannot stop. So it's burning through a lot of calories every second, every hour, all day, and it needs that constant inflow of oxygen. If it gets reduced, then the acute coronary syndrome symptoms start showing up. Many times the syndrome, this set of symptoms, appear in other diseases. So it's not the patient's fault if they feel a certain thing and they think it's not a heart attack when it turns out it is, or when they think it is a heart attack when it turns out it's not. So there's a lot of misdiagnosis going on, and even doctors can do it, which is why the only definitive diagnosis for myocardial infarction, which is the actual disease, are blood labs. But based upon a good patient assessment, it's possible to have a high probability of concluding the correct disease, that this might be a myocardial infarction. The big symptom is chest pain. So somebody calls 911 and they say, I think I'm having a heart attack. Now, the term heart attack is kind of a very vague, non-specific condition. Lots of non-medical people use heart attack to mean 3 or more different things that have nothing to do with each other. They could say that their loved one is having a heart attack, but they're having a cardiac arrest. A loved one could be having chest pain, could be cardiac ischemia or full-on myocardial infarction, or sometimes the person is just having heart failure, which means it's not causing chest pain, but they're having other symptoms. So a heart attack is not a professional term. We sometimes use it as a professional, like I'm using right now, even though we know we're not supposed to. So if somebody calls 911 and they diagnose themselves, the 911 operator turns around and point blank asks, "Are you having chest pain?" It says, and then the patient thinks about it and says, "Yes, I'm having a pain in my chest." And then the EMT ambulance is dispatched and they are sent to a cardiac condition. Not that the EMT dispatcher has definitively figured out this is a heart condition, but that this is the most serious likely cause, and this is the one where minutes count. So please turn on your lights and sirens. Drive with due regard. What's due regard? We'll talk about that in one of the last chapters of the semester. Don't drive stupidly, but drive smartly, wisely, but quickly, because this could actually be a cardiac condition. That said, classic textbook description of acute coronary syndrome is a crushing, dull, heavy, or squeezing feeling in the middle of their chest, just underneath the sternum. We know what, those of you who've been out there in the real world with real jobs, you know how close textbook examples get to real world examples, right? Same thing here. When you get out there and have a real patient with a real cardiac syndrome, it may not be as clear cut as the textbook says, but this is a very typical description of what the patient is feeling. So this heavy feeling can also be thought of as pressure. And what's going on is when you're at the gym or exercising or doing any kind of physical exertion that you're not used to, like you're running after the bus or running down the steps of the subway station because you don't want to miss your train, and this kind of activity is above and beyond what you're used to doing, then your legs or your arms are feeling a burn. You're feeling a burning sensation as the lactic acid builds up, as the oxygen delivered by the arteries is not meeting the oxygen demand that your muscles are suddenly put under, and the veins that are supposed to be carrying away the waste products of physical exertion are not carrying them away fast enough, and waste products like lactic acid and carbon dioxide start building up in those regions. And remember, I said carbon dioxide is an acid, lactic acid is an acid. So the area of muscle is starting to acidify, and the patient feels that area, or the exerciser or the athlete feels that in that muscle as a burn. When this happens in the heart, because something about the blood supply is inadequate, not adequate to the sudden needs of the heart, then the patient starts to feel a burn. But the nerve senses there transmitted to the brain, reported to the patient's brain as a pressure, a crushing, heavy pressure. Now, this feeling can sometimes move. In medicine, we say that radiates, but never ever use the R word to your patient. To your patient, ask if the pain moves anywhere or the feeling moves anywhere. And then again, classically, stereotypically, typically, the patient sometimes says it goes over to their left side. So left upper abdomen, left arm, left jaw. That's classic textbook behavior for ACS. Sometimes it's on the right side. Everybody's different. But statistically, it is numbness and pressure discomfort in the substernal area, just middle of the chest, and also similar feelings on the left arm. Dyspnea, pnea is breathing, and dys is bad, so bad breathing, a feeling like they're having trouble breathing, also found in ACS, and that kind of makes sense, right? If the heart is not doing a good job of pumping blood around, then the body is not getting the oxygen supply it's supposed to be getting, and the body starts complaining to the brain that it's not getting in, it's not breathing well enough, and the patient reports feelings of having trouble breathing, difficulty breathing. Sometimes that's what the call is. You're called to a patient for difficulty breathing or diff breather, and then you get there, and upon proper assessment, you realize this isn't just difficulty breathing. This person is having a myocardial infarction, a acute coronary syndrome. Here's a video explaining the difference between arrest, heart attack, heart failure. So that's a good one. It's a good one to have a look at. Other symptoms and signs that seem to come up more often than not when somebody's having an acute coronary syndrome, feeling of impending doom. So the patient won't say feeling of impending doom, but they will say things like, I think this is it, I think this is the big one, or I feel like I'm going to die. Just they sometimes have hard time putting it in words, but they have this, they know something is wrong, and their body is telling them that something very, very bad is happening, and if they don't take care of it, they may die. So this feeling of impending doom. Epigastric pain, epi on top of gastro is stomach, so on top of the stomach. So go ahead, put your hand over your stomach right now, and by now you should know where your stomach is, and you'll notice now that it's just under the heart. It's kind of like the next door neighbor, not a roommate, but a next door neighbor, and the fence is the diaphragm. So if there is pain coming from the heart, it will be understandable if the patient mistakes it as pain coming from the stomach, because the stomach's like right across, right over the fence. So epigastric pain. Another cause, a possible cause of epigastric pain is that another part of the digestive system that is right next to the heart is the esophagus, the food tube. So food goes, you chew your food, you swallow, it goes from your mouth down to your throat, down into the esophagus, and then passes right behind the heart on its way to the stomach. So pain that was coming from the heart, the patient may sometimes misunderstand that as pain coming from their esophagus, and it comes across as heartburn. The person thinks they're having heartburn, and that's actually pretty ominous, because especially people who have a long history of heartburn, then they tend, if they feel pain in that general area yet again, they may be tempted to just wave it off and say, don't bother me, it's just heartburn, I'll go take a rest, or I'll take some kind of antacid and I'll feel better, it's okay. But no, this time it's not heartburn, it's an actual cardiac event. Sweating is the sympathetic nervous system churning out the adrenaline, epinephrine adrenaline, because it's the fight or flight response. So even if the patient does not think they're going to die, their body is aware that it's going to die, and it's starting to pull out all the stops, trying to save its own life. So the stress response is full on alarm mode, and the person starts to sweat. The abnormal pulse is because the heart is not beating properly. There is a dysrhythmia, and if you show up in time and check their pulse, you'll realize that it's arrhythmia, some irregular heartbeat. You take the blood pressure and it's not normal, and which makes sense, right? The body, how does the body know that something's wrong? Well, because the body is not getting the blood supply it's supposed to be getting, because the heart is not beating the way it's supposed to, and so blood is not flowing. Patient actually is suffering hypotension. So this is where you come in and you ask all about the pain. So onset, provoke, palliative, quality, radiation. Again, never use the R word into your patient. ask them where is the pain and where does it move anywhere, and let them answer. Don't assume you know what the patient is going to say. Sometimes they surprise you with their choice of words and how they say it. Severity 1 to 10, remember to anchor it. Like, what on a scale of 1 to 10, 10 is the worst in your life, what number would you give it? And then T is time, like how long ago did it start? Does it come and go? Stuff like that. And of course, the one more letter, I or you. I is interventions. What did you do? What did you take to try to make it better? Or you can call it you because it's alphabetical. And then U stands for what did you do to try to make it better. Past medical history is part of the sample, SAMPLE. And of course, you should absolutely take at least 2 sets of vital signs. Take the baseline, and then 5 minutes later, take the a trending second set. Patient, again, typically, so this is the typical story. It doesn't always happen to be this way, but typically you come on the scene, and in a general impression, you see age, gender, obvious life threats, and then position, and they're typically sitting up because of that feeling of impending doom. The feeling of impending doom. They're anxious. They're feeling a lot of stress. They're scared. They're scared out of their wits. So of course they're not going to take this lying down, right? They're going to try to sit up because they're worried. They're very, very worried. Oxygen, yes. As you get higher up in healthcare, it turns into a maybe. But at the EMT level, especially for the EMT student, let's just answer with yes for oxygen for now. And then in the respiratory emergencies and later when we're putting it all together in the second half of the semester, we can start explaining at what situations maybe you don't want to give supplemental oxygen, but we'll worry about that when we get to it. For now, anybody with heart condition, especially if they're showing symptoms, then yes, you give them oxygen. Now, how do you give them oxygen? Okay, that's that's worth it talking about, right? Whether you give it nasal cannula at 6 liters per minute, or non-rebreather at 15 liters per minute, or full-on BVM at 15 liters, that's gonna be worth talking about. Shock position. Shock position for person in shock. And how do you know they're in shock? Because they're showing the signs of shock, which is the skin is pale, cool, clammy, their pulse is weak and rapid. And then in the primary, you should put them in shock position, which is lay them down. Except, in most all shock, lay them down. Why do I say most? Well, if the person had some severe trauma and they're bleeding out, like in a war movie, so blood is leaving their body and that's causing shock because of hypovolemia, then, in the movies, the protagonist will lift up the patient into like fowlers or semi-fowlers and say something dramatic like, stay with me, don't leave me, stuff like that. That, for somebody in a traumatic shock or hypovolemic shock, that's like the worst thing you can do. Because remember, which organ are we most worried about? And the answer is the brain. You want to make sure that blood supply to the brain is prioritized. And if you lift up the upper half of their body, which means you're tilting the head to the highest point, then gravity is working against the patient and blood is flowing downhill away from the brain. So in any other shock, you absolutely must keep them flat on the ground. And when you put a patient on the ground, or make them flat, lay flat, then you want to put them supine so you can better assess the airway. And if the patient is in shock, as in systolic blood pressure is inadequate, is too low, the patient is in altered mental status, clearly showing that the blood supply to the brain is inadequate, then also lay them down, because again, the main organ we have to worry about is the brain. We want to make sure blood supply to the brain is adequate. That said, in ACS, in any kind of cardiac condition where the cause of the shock is caused by the heart, genic mean caused by what? Caused by the heart. So cardiogenic shock. If the patient is fully alert and oriented, being alert and oriented means the brain is getting enough blood supply. For the moment, the brain is getting enough blood supply. You don't have to send more blood to the brain. You don't have to put them supine. And then for cardiogenic shock, here's the thing. It could be that the heart is so weak, the heart is on the verge of failure, that it's barely able to do the work it's doing. If you lay the body down, supine, you're sending more blood to the heart. You may give the heart too much work to do, and you may actually cause the heart to get worse. Also, remember, the patient is typically sitting up because they are sensing an emergency. So the epinephrine, the adrenaline is flowing. So they would rather be sitting up, and you don't have a very strong reason to lay them down. So don't force them to lay down. Instead, let them sit up, what we call position of comfort. What's the difference between position of comfort and semi-Fowlers? Semi-Fowlers is when the EMT decides what angle the torso is at. Position of comfort is when the patient decides what angle their torso is at. So you start changing the angle of the stretcher and saying, is this better? Do you want it to be higher? Do you want it to be lower? And then the patient will give a couple of directions, and then finally the patient says, yeah, that's about right. I like staying like this. That's it. That's their position of comfort. This is only true as long as the brain is getting enough blood so that it's working properly. When the brain no longer gets enough blood to work properly, then the blood flow to the brain is inadequate. Now you have to put him supine. So to recap, most all shock, other causes of shock, it's put the patient supine. If it's cardiogenic shock, if you suspect cardiogenic shock and the patient is mentating appropriately, then position of comfort. But if they're not mentating appropriately, if they are altered mental status, which means any one of these 4 questions, what's your name, where are you, what day of the week is it, what do you think is going on, if any one of those questions are answered inappropriately, they are now altered mental status, and you turn them supine. Notice the EMT is at eye level with the patient, so showing respect face to face, so giving the patient signs that you are treating them as a respect, with full respect. Don't talk about, even though she is communicating. Can you see the mouse? Even though this EMT is communicating with the family member, they're not talking about the patient as if the patient is not there. So the EMT is maintaining level of respect, addressing the patient while receiving information from the family member. And here he is getting non-rebreather at 15 liters per minute. Right now, the current recommendation is put a O2 sat, get some O2 sat, like this sensor on the finger here, and you want to see O2 sat percent of at least 94. If it gets too high, like 99 or even 100, then technically they don't really need the oxygen anymore, but maybe switch to a nasal cannula. But that, again, I said that it's for higher levels of healthcare to think about especially at the beginner EMT level, just give them a non-rebreather unless they reject it, switch to nasal cannula. If they reject the non-rebreather, transport it to the hospital. So the next few slides, no, not the next few. There's one slide. Is it possible that you as an EMT may put these EKG electrodes on, even though we're not training you how to interpret them? And in the New York State, so New York State level, their guidance is yes, EMTs may be allowed to place EKGs if their agency wants them to, but the agency does not have to provide all their BLS EMT ambulances with EKG machines. So what that translates into is every agency in the state of New York will see this and say, wait, well, if we don't have to do it, and maintaining EKG machines is pretty expensive, if we don't have to do it, then we won't. We'll only do the things we have to. So that's why still today, unless the rules change, then an EMT bus, 2 EMTs on a BLS ambulance, is still not likely to carry their own EKG machine. Anybody with a cardiac condition should have a paramedic ambulance dispatched to that call anyway. If you show up for like something else, you show up for weakness or dizziness or something like fell off of the bed, and then you show up and then you realize, wait a minute, there's more to this than just fell off the bed. This person might be having a cardiac condition. Then you go to the dispatcher and you call for ALS, and they'll bring their EKG machine as well as their 1 year of training on how to interpret EKGs. So what can you give the patient that you carry in your tech bag? 3 medications. You carry 3 medications that are approved at the BLS level for cardiac condition. The first one is oxygen. Yes, oxygen counts as a medication. Then here's the next one, which is nitroglycerin. And let's see, can you see it on the... Well, it does say, oh yeah, it's right there in front of me. 0.4 milligrams is 1 tablet. So that is the dose for nitroglycerin. You put it under the patient's tongue. It's sublingual under the patient's tongue, and then you tell the patient, just let it sit there, let it dissolve on its own. Do not chew, do not swallow. It'll dissolve on its own. How does nitroglycerin help the patient? It's a vasodilator. Vaso means all vessels. Dilator means gets bigger. How does that help? Well, if it makes all vessels bigger, then the vessel that was supposed to feed the heart gets bigger, which means more blood flows to the heart, and so more oxygen gets to the heart than was happening at the time. And hopefully the patient will feel better, although not necessarily. It does not guarantee the patient will feel better. But the whole point is that it helps prevent further damage. And it doesn't guarantee preventing further damage, but it helps prevent further damage. So nitroglycerin is how it works. A contraindication means even though there's a reason to give it, there is a reason to also not give it. So if the person is having a cardiac condition, that's a reason to give nitro. But with a patient with cardiac condition, there is, and then they answer the wrong way to this question, then that's a reason not to give it. How do drugs like this, in the general category of this, how are they contraindicated? These drugs are also powerful vasodilators, and that's how they work. This time, it's not the vessels to the heart, but the vessels to this other thing. And so when the patient takes drugs like this, they increase blood flow to this organ of his body, and it does the thing they want it to do. But if you take a powerful vasodilator if you take a powerful vasodilator like nitroglycerin and combine it with a powerful vasodilator like this one, then they have a synergistic effect, and that results in their blood pressure crashing. Because of the blood vessels get wider everywhere, larger container, same amount of fluid, the pressure will go down. If the patient has taken one of these drugs in the last 72 hours, 3 times 24 is 72, so 3 days, and now you give him nitro, then you could see the patient blood pressure crash right in front of your eyes. So you're supposed to ask, sir, have you taken one of these drugs within the last 3 days? And if they give you a funny look, then you explain, this medication I'm about to give you is a powerful will drop your blood pressure a lot, and then this drug we're talking about also drops blood pressure. We don't want to combine the two because it could kill you. You could even be that plain about it. If you combine these two drugs, it could kill you. So I'm sorry if it's embarrassing, but you need to tell us before we do something that might be dangerous. And by the way, women take these medications too. Maybe not as frequently, but they are also prescribed medications like this. So you should ask women too. Before you give any medication, we have to remember the 6 rights. What are the 6 rights? Go back to your lecture on pharmacology and review your notes for that. After giving nitro, you are allowed by New York State to give a second one in 5 minutes. But before you do that, since we've been talking about blood pressure, you really want to check blood pressure. Now, nitro won't have an effect immediately. So like as soon as you put one in the mouth, don't check the blood pressure right away. But like 5 minutes after you give nitro, you want to check their blood pressure again. In fact, do the entire vital signs because it's been 5 minutes, and any critical patient, you want to check vital signs every 5 minutes, right? So you want to make sure that the systolic is above the minimum recommended level to give nitro. If it's not, then don't give the nitro because it's contraindicated. So what is the recommended blood pressure level for nitro below which you're not allowed to give? Okay, so your textbook probably says one thing, and then because you want to be a EMT in New York State, you want to follow New York State protocol. So here is a great opportunity to show you how to do it. You go to your favorite internet browser and you type New York State BLS protocols, and see what comes up. And here it is. You want always double check the source. You don't want to accidentally download a file from some malware site. So this one is www.health.ny.gov. So okay, this one looks good. And so here, statewide collaborative protocols effective July 2025. Hey, you guys are just in time to memorize the new state protocols. Let's see. What's the difference, collaborative and BLS? Collaborative includes the paramedic level. BLS is BLS purely, but let's just click the first one because we're used to clicking the first thing. Where we got the 186-page protocol now, of which you should know the whole thing by the end of the semester. You should try to memorize as much of this as you can before you take the state exam. Why are we here? Oh yeah, so let's nitroglycerin, and let's see what comes up. Let's see. So to read a collaborative protocol, adult, cardiac condition, don't worry about this word. You don't need to know it. Cardiac adult. So we have CFR, which is certified first responder, police officers and firefighters. So they can do this. Sometimes firefighters carry oxygen, sometimes firefighters carry aspirin, but that's all they carry for a heart condition. And then at the EMT level, you can do all of the above plus this. So if your agency allows you to have an EKG machine, oh, by the way, why does it keep saying ECG, and why do I keep saying EKG? Culture and tradition, I learned it as EKG, and the original inventor of this machine was German, and in Germany, cardio is spelled with a K. Now in America, it's spelled with a C, that's why it's ECG. But the problem with saying ECG is that there's another machine that's popularly used called an EEG, electroencephalogram, and that is measuring brain waves in the head. So to avoid mispronouncing or getting misheard across the radio or in a hospital setting, most of us tend to just say EKG because it's more obvious to the listener that we meant this. Anyway, if you have an ECG machine from your agency, then go ahead, use it. Something tells me you're likely not to have it. Anyway, here we are. Next step is you can assist the patient with their nitro. With their nitro. You carry nitro, but they have, if the patient has their own nitro, you can give up to 3 doses, 5 minutes apart, as long as the blood pressure is over 120 systolic. So there it is. From the horse's mouth, from the man himself, the number is 120 millimeters of mercury. If your textbook says something else, we'll probably design our test questions, our final exam questions, to stick with the 120 because we don't want to confuse you for the state exam. And now, you may give one of the patient's nitros, but if you want to give more than that, or if the patient does not have nitro, they were not prescribed, but you feel like, but the protocol says you can, then you may give yours. But any dose more than 3, you have to call for medical control's permission. So to give the 4th dose, remember they're 5 minutes apart, which means 20 minutes after the first dose, you feel like this patient really needs a 4th dose and you're nowhere near the hospital, then you have to call online medical control and ask for permission for a 4th dose and 5th and 6th, etc. And then that's all you're allowed to do. So EMTs are allowed to do this part. I see paramedics have the same criteria, but then don't worry about this. This is not for EMT level. Okay. So no mention of those other drugs for erectile dysfunction. Why not? So let's go check it out. So that word doesn't come up. ED. Oh, of course ED is there. Okay. So New York State apparently doesn't say much about those medications, but the reason why we're making you learn it to ask it if the patient is having it, is because many of you probably expect to work in a local area. So let's look up New York City VMAC protocol. So this is the city protocols, and you should remember that the state exam will not test on this. However, where I'm only going to the city protocol because to see if they have anything to say. So you cannot give this if the patient used this within 3 days, 72 hours. So here, if you want to work in New York City as an EMT, you have to remember this. That's why I'm mentioning that in this lecture video. Aspirin. So certified first responders like firefighters carry it, you carry it, but you have to note that it's this kind, chewable aspirin, 81 milligrams each, and you give up to 4 because 81 times 4 is 324 milligrams. So you're allowed to give up to 324 milligrams at a time of aspirin. So let's go back to the protocol here. This is state protocol aspirin. See, 324, which is for the little ones, and then that's it. And remember, EMTs can do this. Okay, so aspirin is next mentioned. You can, this time, do not give the patient's aspirin. Do not give the patient's aspirin. Only give your aspirin, because it tends to, aspirin bottles in the patient's home tends to fill up with things that are not aspirin. It could be children's chewable vitamins in there. It could be containing some other medication. They're not, patients' own home aspirin bottles tend to be a little suspect. Instead, you bring your own. And also, many of the aspirin that patients have at home, it may be enteric coated. Let's go. I think we don't need the reback anymore. Let's go to enteric coated medication, and this is what I'm talking about here. You see labels like that, and what enteric coated means is they cover over the pill with this thing that will make it take longer to dissolve in the stomach, because they want it to dissolve slowly. But we don't want that to happen with a cardiac event. So you do not want enteric coated aspirin. And to make sure that's the case, you bring your own. And that's what you have in this ambulance. At the beginning of each shift, you always check all medication vials for expiration date. That's one of the 6 rights. And you see that it's 81 milligrams each. Now, there is by culture, it tends to be called children's aspirin, but that's actually a marketing thing. And it's actually very unfortunate, because actually children should not be given aspirin. So why did this company call it children's aspirin? Because they're selling it at small dose vials, small dose tablets, and they needed a way to like separate it out from like larger dose adult sizes. So they called it children's aspirin. Later it turns out, no, actually you're not supposed to give aspirin to children. What's an indication for aspirin? Chest pain. That's it. You may not give your aspirin to a patient for any other reason than a possible cardiac event. Do not give it because the patient is complaining of like muscle pain or bone pain or joint pain. That's called practicing medicine without a license. You must stick to the protocol. If you want to give aspirin for any other reason, and you think it's really justified, then what you do is call medical control for permission. That's it. You cannot give aspirin for any other reason than a possible cardiac condition, and you'll know it's a cardiac condition or possible because they have chest pain. It could be that the chest pain is for some other reason. They called 911. The dispatcher asked, "Do you have pain in the chest?" And they think about it and they go, "Yeah, I have a pain. It's in my chest. So yes, I have chest pain." And so you're sent to a cardiac. But when you show up, it turns out this patient is not having a cardiac condition. It's something else, like muscle pain. Maybe they pulled the muscle from laughing too hard at the comedy show last night, or they were walking to the bathroom in the middle of the night. They bumped their chest against the cabinet, and that's why they're having chest pain. But still, unless you can definitively confirm that it's not coronary, which is kind of hard to do, and it's kind of not our job, then you only give aspirin for chest pain. Of course, don't give anything to anybody if they're allergic to it, which is why you should ask the sample questions before you give any medication. In fact, you have to do everything else before you give medication. Of course, you do the primary, but you also have to do the physical exam. You have to do the OP, QRST, and the sample questions. You have to do full set of vitals, and then you're allowed to give an intervention, a medication. If you don't, you lose points on the practical skills exam. But in real life, you could end up giving medication to something that the patient was not suffering from. You misdiagnosed the patient, and now you're giving the wrong thing. And you misdiagnosed it because you didn't do a complete assessment. So interventions, EMS interventions, always happen at the end after you've done everything else. About the only thing in patient assessment that happens after interventions is the ongoing assessment when you are transporting. Asthma seems to interfere with asthma, so this is a good reason to call medical control. You can have like somebody who is an asthmatic and having chest pain. Is it possible that an asthmatic is having a heart attack or a myocardial infarction? Of course it's possible. But before you give that person aspirin, call medical control. Again, check the 6 rights before you give somebody something that gives somebody bad medication. What are the 6 rights? Go back to your notes on pharmacology. So we just looked up what New York State says. So those were the 3 medications: oxygen, nitroglycerin, and aspirin. All right, so what is a cardiac condition? What's causing it? Why is the heart having such a bad time? Well, it could be a lot of things. But typically, a common cause of why you're there, why they call 911, is that the artery to the heart got blocked. Hey, wait a minute, there are arteries to the heart? Isn't the heart full of blood already? Why does it need separate arteries? Because a lot of the cells of the heart are too far away from the chambers of the heart, the atria and the ventricles, to benefit from any of the blood in there. And remember, the right side of the heart is deoxygenated. There's venous blood on the right atrium and the right ventricle. So cells that are like all the way over here is not anywhere near oxygenated blood anyway, so they need a blood supply. So that's what we have here. These coronary arteries branch out. In fact, they're the first branch out of this giant aorta. They're the first exit off of this massive superhighway, and they're heading straight for the heart. And they branch into arterioles, and they touch every part of the heart, because every cell in the heart needs blood too. Now, some of these vessels sometimes don't do a good job of blood flow. And a common reason why, not the only reason, but a common reason, especially here in the United States, especially in Queens, New York, is a disease where fatty deposits build up inside the arteries, reducing the amount of blood that can pass through. So on the outside, it looks like they have an ordinary looking artery, but if the pathologist on autopsy cuts this open and looks inside, they'll see that it's full of these fatty deposits, reducing blood flow. And we call that atherosclerosis. Athero, which means a fatty deposit causing a hardening of the heart. Sclerosis is a hardening of the heart. What's a common cause of atherosclerosis? Bad living, eating too much, exercising too little, using voluntarily ingested toxins. So eating too much, especially carbohydrates, causing obesity, exercising too little, so you're not burning off the calories you're taking in, and then voluntarily taking toxins such as alcohol, tobacco, party drugs. So I say voluntarily intaking, meaning nobody's forcing them to get a smoke and have a drink, but the patient willingly does it of their own free will. And after years and years of that hard bad living, they end up with atherosclerosis. Now, somebody who lives a very clean life could still end up with hardened arteries, which is arteriosclerosis, but the arteriosclerosis is possible because it's just simple old age. Nothing lasts forever. Every cell has a timer. and when the cell gets old enough, it just eventually degrades. We call that senescence. So sclerosis happens anyway to people who live long enough, like hundreds of years, 100 years, I guess. But some people live beyond 100 years old, like a few years beyond that. But a subset of arteriosclerosis is atherosclerosis. Okay, so here are two words that sound really similar, and it can be understandable if the brand new EMT student who has like too many other things they're supposed to memorize come to this point in the quiz or the exam and they're like, I forgot which one is which. So here's a little trick. If you put the letter F in front of the word, the first three letters spell fat. So atherosclerosis is the result of fatty plaques that build up on the inside of the artery. If you put the letter F in front of this word, it spells that. And then people who are old tend to do this a lot. So that's arteriosclerosis. So now you know the little trick. Put a little F in front of the word, and if it spells fat, it's the fatty plaque buildup causing the sclerosis. If it spells something else, then it's hardening of the arteries from simple wear and tear. Everything breaks down eventually. Nobody lives forever. So here is atherosclerosis. Now, sometimes it's not a coronary artery, but some other artery that has gone atherosclerotic. However, these are fatty deposits, right? And under this constant turbulent blood flow, what if a piece of that fat breaks off and starts traveling with the stream, and then ends up here? Well, any clot that forms, any piece that breaks off forms this rough surface, and then the platelets, the thrombocytes, when they bump up against any surface that they're not expecting, they will activate and form a clot. So this fatty piece, the piece of fatty plaque, activates the platelets around it, and it starts to form a clot. When the clot is staying in place, it's called a thrombus. When the clot is traveling with the flow of blood, it's called an embolus. But just like a snowball that rolls downhill, just like a snowball that rolls downhill, the clot that travels will bump into more platelets and get bigger and bigger and bigger. And meanwhile, the artery is getting smaller and smaller and smaller. Eventually, the embolus will run into a narrowed artery or arteriole, and it gets stuck. Which means then that the area downstream from this artery is not getting blood flow. So let me transfer this to my favorite editor, and there. And so let's put a little clot. I don't know what color clots are supposed to be, but let's say the clot travels here and gets stuck in here and jammed in here, and then what's happening is the area downstream that's supposed to get a blood supply does not. So what happens to the cells down here that are expecting their usual shipments of oxygen, sugar, and nutrients, but they don't get it, and they start to complain? Thrombus, emboli. So the myocardium, muscle of the heart, myocardium, when the cells don't get enough oxygen, when they don't get enough sugar, well, here in Queens, New York, sugar supply is not really that big of a issue. Yes, some people do starve to death in this great city of New York, but the majority of the cardiac calls in New York City are for oxygen, and the cells start to complain. When the cells complain, and they complain by sending pain signals to the brain, and it's from lack of oxygen, we call that ischemia. But ischemia is reversible, meaning that they call 911, you show up, you're a good EMT, you do your job well, you get the oxygen on, You give them the aspirin and the nitroglycerin, and then oxygen is returned to the cell stops complaining, the ischemia goes away. Ischemia is reversible. If you show up too late, or let's not make it your fault. If the patient delays too long, and so from their own will, free will, they don't call 911, then the cell will keep complaining and complaining, but the cell is running out of oxygen. And remember, when the cells run out of oxygen, they switch from aerobic respiration to anaerobic respiration. And the problem with anaerobic respiration is that it doesn't make enough ATP. So the cell not only runs out of ATP to do for the energy for functions to stay alive, but there's a buildup of lactic acid, and which is a result of anaerobic respiration, and the area becomes more and more acidic. Finally, the cell dies, and then they finally call 911, or their loved one, their family member finally calls 911 for them, and you show up and you finally give them the oxygen, but it's too late. The cells are dead. You cannot revive dead cells. You have to just wait for like new cells to be born in a repair process that takes weeks to years. Days to weeks, but not today, not in the next few minutes. And then if the damage is too far, too extreme, too extensive, then instead of repairing that area with new cardiac muscle cells, instead it's replaced with scar tissue. What do you think will happen to the electrical conduction system if one area, instead of being made up of cardiac conduction cells, is made up of scar tissue? Then the electrical signal does not pass normally through that area, and that causes dysrhythmias. People with prior myocardial infarctions are ever more likely to have a future myocardial infarction. Where were we? Are even more likely to have a future myocardial infarction. Infarction is cell death from lack of oxygen. Any cell death from lack of oxygen. Can you have a non-cardiac cell, like a lung cell or a foot cell or a hair cell, die from lack of oxygen? Yes, they can be infarcted too, but those tend not to be life-threatening. A cardiac cell infarcting is life-threatening, because not only does that cell, that rower, that guy in charge of supporting, I think it's this slide, that sailor in charge of rowing their section of the ship is no longer doing their job, but the cardiac conduction that they're supposed to be contributing to is also not happening. There's a likely chance that they will have a further dysrhythmia in the future and another infarction. I just realized that I forgot to talk about how aspirin helps. I told you how nitroglycerin helps. Nitroglycerin is a vasodilator. The aspirin helps by being a platelet disaggregator. Did I actually say that? I didn't say that. Here, let's put this in here. Aspirin. Sorry, I have a new keyboard. I'm still not used to the buttons. Aspirin is a platelet disaggregator. Uh-oh, there's that DYS in there. Are you sure that's good for the patient? What is it dissing? What is the aspirin dissing? It's dissing platelet getting stuck. Aspirin helps reduce the rate that platelets do their job. Did I spell platelet correct? I did. Always check your sources. Who says I did it? No source. Well, at least it doesn't say AI result. Wikipedia, Cleveland Clinic, myclevelandclinic.org. Okay, so that's an old reliable source. I've used this website often, and they spell it this way, so I'm good. Aspirin helps. It doesn't guarantee, but it helps reduce the rate that platelets do their job, which means down here, as the platelets get stuck on, down here, as the platelets get stuck on the embolus and keeps making it grow like a snowball. Oh, I closed that window. Well, like a snowball. If you took aspirin, it slows down that process, which means the embolus does not keep growing and growing and growing. It still grows a little bit, but not as much. So that's a good thing. You want that to happen. If and only if the patient is having a cardiac condition. Can you think of a situation where this kind of function is like bad? Like you definitely do not want this happening to a patient? Because when would you want somebody to grow clots in the normal speed, in the normal way? And I'm hoping that all of you are mumbling right now, what if they're bleeding? Like if somebody got a paper cut, you definitely would not want to give them aspirin because it makes it hard for them to stop bleeding out of the paper cut. What if they're having a gunshot wound? Then you definitely do not want to give them aspirin because blood is draining out of their body. You want that to stop. You don't want that to get faster. So you want patients to form clots when they are losing blood, when they're bleeding. But hopefully this patient is not bleeding, they're having a cardiac condition, and then it's okay to mess around with their ability to form clots. Now, does this mean aspirin is a blood thinner? No, aspirin is not a blood thinner. A blood thinner takes clots and helps them dissolve, but aspirin does not do that. Nowhere in this phrase does it say aspirin dissolves clots. It only stops current clots from getting bigger, or it slows down the rate that current clots get bigger. So that's not blood thinning. Officially, it's platelet disaggregating. But anyway, that's how aspirin helps. Aspirin will not help the patient feel better because the clot is causing the pain. And the aspirin does nothing for that current clot. But what aspirin does, and the life-saving effect of aspirin in a cardiac condition, is that it helps prevent whatever cardiac condition the patient currently has from getting worse. That's why you give aspirin. Don't make the fallacy then of giving aspirin to your cardiac patient and then saying, okay, now I'm going to ask if the patient feels better. That's not how this works. Which brings us out of that side quest down to this slide here. Speaking of bleeding, all the examples of bleeding I gave you before were external bleeding. It's possible for a patient to bleed internally. And one way a patient may bleed internally is that one of their arteries burst like a balloon. This is a burst aneurysm. The aneurysm is the bulge in the it's the bulge in the arterial wall. Why would it do that? Manufacturing defect. Ever get a balloon, a bag of balloons from the 99-cent store, and as you're blowing them up, one of them is like expanding in a weird way, and it's because they're cheaply made and one of the walls of that balloon is weaker than the rest, and so it starts to bulge out. That's kind of what's happening here. Something about this artery has a weakened wall, and with the constant blood pressure, it starts to bulge out. That's the aneurysm. Now, what if it bursts? Why would it burst? Because this weakening process is continuing, but at the same time, something spikes the blood pressure, maybe like extreme emotional situation or high stress situation, or they took a medication that increased their blood pressure extremely, like a party drug, or you gave the wrong medication and it's upping their pressure too much, like epinephrine to somebody who doesn't need epinephrine. So a combination of weakened wall and then a spike in the blood pressure causes the vessel to burst, and the patient is now suffering internal bleeding. That's a burst aneurysm. If it's a large enough artery, the patient feels a tearing feeling. How big does it have to get? How about as big as the largest artery in the body, which is the aorta? So it could happen that an aneurysm appears in the aorta and it bursts open, and that could be a aneurysm, a burst aneurysm. Okay, weakened artery wall, and then high blood pressure, spike in the pressure, and the aneurysm bursts open. The buildup of the aneurysm is a very slow process, but the bursting is a sudden, immediate process. So it could be acute coronary syndrome, like I have chest pain, it happens suddenly, like today, and so 911 operator says, do you have a pain in your chest? And they say yes. So you come in expecting an ordinary heart attack, but it's actually a burst aneurysm. Typically, the patient describes it as a tearing feeling. So that's something, right? The Q of OPQRST. In your own words, please tell me how the problem feels like. And you're expecting them to say like a pressure, a crushing feeling, but instead they say tearing feeling. So that's their first clue, that it's a aneurysm. Dissecting aneurysm. A dissecting aneurysm is slightly different. Well, it's actually pretty significantly different. Instead of a bulge bursting, the aneurysm is is the walls of the artery being split open. Dissecting means split open from the inside. And then that's a sign. Okay, so how does that work? Here is a diagram of an internal membrane of the artery, the tunica intima. I don't think EMTs need to know the tunica membranes. I'll have to double check on that, get back to you later. But the internal membrane, the tunica intima, under all this constant pressure, because imagine like water going down, coming out of a garden hose where the faucet is turned way up. So that much pressure constantly can sometimes tear a little rip in there, but then the continuing pressure causes that rip to expand downstream. And since the aorta, it comes right out of the left ventricle, the pressure here is actually going to be the highest. So it tends to happen here more often than other places. And that could be a dissecting. And so the tearing, as it's ripping from source downstream, could be what the patient is feeling. What if this tearing, this dissection, happens in between the branch to the right arm and the branch to the left arm? So it happens around here. If you took a blood pressure on the right arm and then took a blood pressure on the left arm, would the two numbers be similar, like they're supposed to be, or will they be different? I'm going to leave that as an exercise, a thought experiment for the A students of this class. Those of you who are trying to get an A, you come back to me and let me know. What would you expect the blood pressures to read if the patient has a dissecting aneurysm right here? Any kind of change in blood pressure is called an orthostatic blood pressure, meaning that if they're sitting versus standing or versus lying is different, significantly different, after waiting about a minute. actually, I should say sitting versus lying, because if you ever have a reason to get orthostatic pressures, then you are kind of saying you're worried about their heart, and you should never make a cardiac patient stand. Don't ask the patient, please stand up while I take a blood pressure, because if they like faint and hit their head on a table as they fall, it's all your fault because you're the one who told them to stand. So never make a cardiac patient stand. Instead, get orthostasis between sitting and lying. And if you wait about a minute or two and then get the second set, and then you compare the numbers, and if they're different, you can say they are orthostatic. Because normally it's supposed to be similar. The numbers are supposed to be close, sitting versus lying down. If they're greater than more than 10 points, whichever one, the systolic, diastolic, or heart rate, it's called a orthostatic hypotension. It means the heart is involved. Hypertensive emergencies could cause a burst aneurysm, but it can cause other problems like a stroke. And a stroke for hypertensive emergency is when there's a burst aneurysm. One of these things happen in the patient's brain, in their skull. Hypertensive emergencies can cause a pulmonary edema, so refer to the respiratory emergencies chapter for explanation of pulmonary edema. Anybody with a blood pressure greater than 180 systolic, it's a hypertensive emergency. Some of their symptoms are here. You can pause and read this for yourself. This person really needs to be transported to the emergency room, lights and sirens. If you can get paramedics on board, maybe make them meet you halfway, like at a rendezvous point, that would help because they can give some medications to bring the pressure down on the way to the hospital. It's all about getting them to definitive care before they have the full-on stroke or before they burst, before this happens. Get them to the emergency room before this happens. Before I leave this section about aneurysms, I want to talk about this thing. So in the abdomen, we have an aorta going down the abdomen, right? What if the bulging happens in the abdomen? Then what would happen? If you place your hand over the belly, not squeezing, not pressing, just rest your hand on the patient's belly while they are supine and relaxed so they're not flexing their abs, and you feel a pulse. That's bad because you're not supposed to feel a pulse on their belly. If you feel a pulse in the belly, what you're feeling is an aneurysm pulsing away. The systolic is coming down with every heartbeat, causing this to bulge rhythmically. You feel and this is the phrase you tell the emergency room: I felt a pulsatile abdominal mass. And the nurses will panic, the doctors will panic. They think this patient is having a AAA, an abdominal aortic aneurysm, and they need to get this person on pressure meds to bring it down, and they need to get him into surgery to reinforce that section of the bulge before it bursts. Because once somebody has a burst abdominal aortic aneurysm, that's it. They're dying. They're going to die. That's it. There's nothing anybody can do. CPR compressions will only pump more blood into their abdominal cavity. There's nothing anybody can do once it bursts. That's it. They're a goner. The only way to deal with this is to prevent it from bursting. In fact, if you suspect a AAA, you do not go lights and sirens because that will excite the patient and it'll cause them stress and it'll cause their blood pressure to go even higher. So going lights and sirens with a AAA increases the chances that it will burst. Instead, you take it smooth and slow, gentle, be calm with the patient. Don't say anything that'll upset or excite the patient. Just make your way to the hospital. At the very least, get them to paramedic level care, either a local emergency room or paramedic. Rendezvous with a medic unit, or if no medics are available, get them to a local emergency room so they can get blood pressure meds to bring it down fast. And then they need to go to a full service emergency room so that they can get into surgery and get that abdominal aneurysm secured. Okay. You've heard me say this word, myocardial infarction, a few times in the lecture so far, and here it is spelled out in its full glory. Acute, so short term. It's not been there for months and years. It happened over hours and days. Myo, muscle, heart, death from lack of oxygen. So this is the big one there. Other problems, angina pectoris or angina, the pronunciation doesn't matter. It comes down to who was your teacher, where you learned the pronunciation, because half the doctors in the world call it angina. I'm sorry, a third of the doctors in the world call it angina, a third of the doctors in the world call it angina, and the remaining third alternates between angina and angina. So the pronunciation doesn't matter. Pectoris means in the chest, so a pain in the chest. Chest pain is angina pectoris. It could be one of 100 different reasons. It could be you pulled a muscle laughing too hard. It could be you bumped your chest on the cabinet, causing a musculoskeletal injury, or it could be ischemia, or it could be infarction. It could be an embolus in the lung, a pulmonary embolus, making it hurt to breathe, and that's why they have a pain in the chest. So that's angina pectoris. Heart failure often ends up in congestion, and there's a few slides on that. So you may have heard of it as CHF, and that's what this stands for. Now, heart failure does not mean cardiac arrest. A stopped heart is arrest, so cardiac arrest. Heart failure is when the heart is pumping but not well enough. Like if somebody gets 50% on an exam and the teacher says you failed, and the student says, what do you mean I failed? I got 50% right, so I know at least half the stuff. And the teacher is like, yeah, but you don't know enough. Passing around here is 75%, you only got a 50, you failed. So heart is beating, but it's not beating enough. The cardiac output is not high enough, so it's cardiac failure. So pain in the chest could be caused by any number of things. It doesn't have to be infarction, but it could be, and there's no way to tell the difference. There's no way to tell exactly what's causing the pain in the chest until they go to the emergency room and get blood labs. Three cardiac enzyme labs, an hour apart, spaced an hour apart, is the definitive way to confirm or rule out myocardial infarction. Angina pectoris actually has stable and unstable versions, and the unstable version is the more scary version. Chest pain that's stable, how is that? Well, if the person is physically exerting themselves, it causes chest pain, and then when they rest or take a load off, they chill out, then they don't feel pain. So that's predictable. That makes it stable. And this is likely because that artery to that part of the heart causing the chest pain is narrow from chronic inactivity, overeating, and voluntarily taking toxins. So the artery is narrow, so whenever they try to do something unusually active, then the heart needs to work harder, and then the arteries for that part is inadequate for the increased activity, and they feel the chest pain. If the person is feeling chest pain for no logical reason, they may even be taking a nap, they may be chilling on the couch, no physical exertion, but then suddenly the pain appears in the chest, and they try to relax, they try to take it calm, They take a glass of water, nothing is helping, the pain does not go away with rest. And even if it suddenly disappears for no reason, the fact that it appeared for no reason makes it unstable. This is probably because the clot broke off and is traveling downstream and suddenly got stuck in one of the smaller coronary arteries, and now that part of the heart is dying. It's going ischemic. It's already gone ischemic, causing the chest pain. And if this person doesn't go to the emergency room and get it dealt with in time, the part will go infarcted, and that's it. That part of the heart is dead. It's not coming back. It's gonna, if the patient survives, they've got scar tissue there. They're going to have an arrhythmia. The chances that they'll have a future heart attack are even much higher. Future MI is even higher. This is why it's so serious. So when the patient complains of chest pain, you hope that it's something benign, something minor, silly, but you be ready for the more serious possibility, because it might happen. And you don't want to be the EMT that does nothing, doesn't do the right thing because you were hoping for the best. You want to be the EMT that does the right thing because you were worried about the worst. And the worst here is myocardial infarction. You know that it's not definitive, but one characteristic of an infarction is that you show up and give nitro, you give oxygen, and it's not helping. The pain is still there, and that makes sense, right? Because that part's dead, and the area around it is dying, and it's complaining, and it's sending pain signals to the brain, so the pain is not going away. And I want to emphasize, this is not definitive. The pain not going away or is going away is not definitive, because you're not there to make a diagnosis. You're there to provide oxygen, appropriate therapy, and transport. There are some patients for whom they are having a full-on AMI, but they're not feeling chest pain. And the reason why, well, there could be a bunch of different reasons why, but two groups of people for whom this is seen more often than others are women and diabetics. Now with diabetics, I kind of understand, because where does diabetes damage the body? And it's every body part everywhere. Uncontrolled diabetes damages every organ everywhere. Some parts of the body, the damage is more noticeable earlier than other parts of the body, but it still damages every part of the body everywhere. Uncontrolled diabetes. So one part that's included of the every part everywhere are pain nerves from the heart going to the brain. If those nerves are damaged and no longer functioning properly, then the diabetic's heart could be trying to call alarm, trying to send out pain signals, but the brain is not receiving it. It's sort of like a car owner who has a sick, bad engine, but the check engine light wire, the wire that goes to the check engine light on the dashboard, is cut. So the engine is trying to tell the driver something is wrong, but since the driver does not see the check engine light go on, they think nothing is wrong with the car. So that's diabetes, silent MI. Silent because there's no chest pain. Women sometimes have silent MIs too, and this one I don't understand as well. I've asked other experts on this thing, and the best explanation I seem to get is that they have a different experience of pain. So whatever they're feeling, some women don't interpret it as a pain, and they think it's some other thing. And then later, as they look back on their experience, they go, oh yeah, I guess I was having chest pain. But at the moment, they did interpret it as pain. So when the EMT shows up and they say, are you having chest pain? Or they call 911 for some other reason, especially severe sudden weakness, and the dispatcher says, are you having chest pain? And they say no, So the EMT gets sent to the woman's place responding to sudden weakness. But then when they get there and they see other signs and symptoms of the acute coronary syndrome, remember syndrome, and they ask, wait a minute, you seem to have a lot of the things with acute coronary syndrome. Are you sure you're not having chest pain? And they say, once again, I'm pretty sure I'm not having chest pain. Then what the EMT should do is say, this is possibly a silent MI. And they should call for paramedics. You know, a paramedic is not a bad idea for anybody with sudden weakness. But if the EMT show up first and they see many of the other symptoms of ACS except chest pain, they should tell the dispatch, either get us ALS or tell the ALS that is coming to our location to step it up, because this might be a silent MI. Why paramedics? Because they'll get the EKG on, and the EKG is one more way to look for signs of a myocardial infarction. MI, so cell death, on autopsy, like this is a slice of the heart that was cut away on autopsy, but then an artist's representation of it, could be transmural, means mural is wall, trans is across, so the entire wall is infected or affected, and this whole section died. So that's a pretty sizable coronary artery that is involved. In fact, the most worrying coronary artery that seems to cause more deaths than others is the left anterior descending. You don't need to know that as an EMT, but when it gets this big, the area of death, infarct, gets this big, it's a major coronary artery. So the cells die because of inadequate blood flow, and the blood flow is inadequate, possibly because the heart is not pumping properly. If it pumps enough so that the patient doesn't have chest pain, but it does not pump enough so that patient has other symptoms, it could be congestive heart failure. So where have you heard the word congestion before? Probably in a setting like this. We're done with the remag. Here, let's go get traffic congestion, right? When you get the traffic report and they say like there's congestion on the Long Island Expressway, etc. And what happens? There's either an accident or some kind of obstruction or just plain old volume of traffic. But let's use the accident analogy, and there an accident somewhere on the, I like the first picture actually, an accident somewhere like here, here's one right now at this time of the day here. Oh yeah, there's an accident here right now on the westbound Long Island Expressway, and it's causing this backup of traffic as they're waiting for their turn to get past the point of accident. So they call this section congestion. And similarly, if the heart is not pumping blood through the heart well enough, then the blood that's in the vena cava waiting for their turn to get into the heart is delayed, which means the blood in this is slide 56, which means the blood in the veins waiting to go into the vena cava is waiting for their turn to get into the vena cava. Everything is backing up, and that's congestion. See, I told you guys in the beginning of this lecture that you need to memorize blood flow through the cardiac circuit, because once you've memorized that, now you'll understand how congestion goes, because you just go backwards in the cardiac circuit, and that's the direction congestion goes. All right, so we've got, back to slide 56, we've got blood not passing through the heart, so which means it's delayed getting out of the vena cava, which means it's delayed getting into the vena cava, And then where is this blood coming from? It's coming from the veins into the vena cava. And where are the veins coming from? And in terms of congestive heart failure, the two most typical, well-known problems is blood coming from the legs. Venous blood coming up from the legs is being delayed in their approach to the heart because of all of this traffic congestion. And when the blood pressure in the veins, not the arteries, but the veins are building up, water tends to start leaking out of the veins under that kind of pressure, and then we have swelling. So one sign of congestive heart failure is swollen ankles, swollen feet, swollen ankles. Do you have relatives whose ankles and feet look like this? It's congestive heart failure. This person is checking for pitting edema, where you push your finger into an area of swelling and then see if the pit is left behind. So that's something that edema, which is swelling from congestive heart failure, tends to do. Let's go back to the cardiac flow. Okay, so that's blood trying to get into the right side of the heart is backed up, and then some of that blood came from the legs, but the legs are getting, the veins in the legs are getting congested, and then that causes water to leak out and causes swelling in the legs. What about the left side of the heart? If the left ventricle is not pumping blood out at the rate it's supposed to, then blood is backing up into the left atrium, and then it's going to where? Where's blood supposed to come from that goes into the left atrium? And the answer is from the lungs. So blood is backing up backwards through the pulmonary vein into the lungs, and just like we have swelling in the legs from the left side of the heart, the right side of the heart, we now have swelling in the lungs from the right. I'm mixing up my lefts and rights. Just like we have swelling in the legs from congestion from the right side of the heart, we have swelling in the lungs coming from congestion in the left side of the heart. And instead of pedal edema, foot edema, we have pulmonary edema, and that's another symptom of congestive heart failure. Pulmonary edema. So what's a symptom of pulmonary edema? Well, you can't look at somebody's lungs and see that it's swollen, but remember how lungs is supposed to work? The capillaries are supposed to surround the alveoli. I thought I drew a picture of that. Let's get it on to alveoli anatomy. So we have blood vessels, the pulmonary capillaries surrounding the alveoli. Remember these sac of grapes. But now water is leaking out of these vessels because they're under so much pressure from the congestion. And the water, where does it go? It goes into the alveoli. Water fills up the patient's alveoli. This patient is literally drowning in their own fluids because their alveoli are flooding with water. How do you know it's happening? Because the patient is suffering severe dyspnea, difficulty breathing, and their sputum, the spit they're coughing up, is foamy because air and water is mixing here and then being ejected up the bronchioles with every exhalation. And sometimes the foam is pink because blood cells are under all this pressure. Sometimes red blood cells leak out too and get into the alveoli and are sent up into the mouth. So the foam is sometimes pink. So it's pink frothy sputum. Pink frothy sputum is the description. Cyanosis, because they're just not breathing. They are literally drowning while they are laying in a dry, warm bed. They are drowning inside themselves. So they're going cyanotic. Their blood pressure is elevated typically because that's what's causing the congestive heart failure to begin with. They're sweating like crazy because they're panicking. They are feeling themselves suffocating. Here's a video of the auscultation of pulmonary edema. So these are the rails and crackles. If you you don't have to stop there. You can keep searching for sound samples of rails and crackles, and there you've diagnosed pulmonary edema, swelling in the lungs. Now, people with pulmonary edema often typically complain of a situation called paroxysmal nocturnal dyspnea, difficulty breathing in the middle of the night, and it happens suddenly without warning. That's paroxysmal. What's causing that? Well, here's the pink frothy sputum. So let's have this going on. It's kind of like this. New keyboard, not really used to it. I hope I didn't. I clicked on the wrong key. I don't know what it does. I hope I'm not going to regret it. Okay, let's do that. Let that. So we've got a lung here, and we got the other lung. Remember to put the cardiac notch in that lung here. The right mainstem bronchus tends to be like more vertical. The left mainstem bronchus tends to be more horizontal. Okay, and then we've got pulmonary edema, and it's flooding the lung. So, oops. So let's make a cartoon about the lungs being flooded. So the bottom lobes of the lungs, because of gravity, are flooding more than the upper lobes. So the patient can still breathe with their upper lobes of the lungs, not so much with the bottom lobes of the lungs. But now see what happens when the patient lays down in bed. Doesn't matter. They lay down in bed. What happens? What does gravity do to the water? Oh, I missed the spot. What does gravity do to the water when you're lying sideways? It floods all the lobes of the lungs. So when the patient lays down flat, they are flooding all their lungs. They can't breathe at all, and they wake up suddenly gasping for breath. But then what happens when they wake up and sit up? Then the water pulls down. Then the water again pulls down to the lower lobes as before, which means they can breathe with their upper lobes once again. So it's paroxysmal. This patient figures it out. It happens often enough that they figure it out. So what patients with congestive heart failure tend to do is they sleep in a way that they are semi-foulers all night. How can you do that? By sleeping on multiple pillows. So those are the three big symptoms: pink frothy sputum, paroxysmal nocturnal dyspnea, rails and crackles on auscultation, and the other one is pedal edema, swelling in the feet. And then for the A students out there, you can have some follow-up questions like, how many pillows do you sleep on at night? And they say 3 or 4 or something like that. And then you ask, what happens if you don't sleep on that many pillows, like just one pillow like everybody else? And they say, I suddenly wake up having a hard time breathing. Okay. So now I notice, sir or ma'am, I notice their feet are swollen. What are they like when do they get the most swollen? And they say by the end of the day, when they are like, yeah, they get worse all day. Why? Why do you think the patients Why do you think the patient's legs get swollen during the day? Because they're like this most of the day. Or maybe they're like this. Maybe they're like this most of the day, right, on a chair. So gravity is pulling the water down to their feet. So their feet are swollen most of the day. But then what happens is they go sleep. And then they're sleeping on multiple pillows on top of their bed. So what happens to the swelling that was on their feet throughout the night? The water distributes more evenly throughout the lower half of the body, and the swelling goes down. So swelling of the feet, pedal edema, is worst by the end of the day, and at the beginning of the day it's not so bad, or it's less. There, those are all the syndromes for congestive heart failure. We can't do much about the swelling of the feet, except the doctor can, at the hospital, the doctor probably tries to get their blood pressure down in the long term by giving them water pills to make them pee the water out, which reduces blood pressure, encouraging them to exercise more, eat less, so slowly bring down the stresses on the heart. But what about the short term, like when you're there? What, as an EMT, can you do, not about pedal edema, but about the pulmonary edema? And remember, it's water pressure building up in the alveoli. And so what we do is give CPAP, because CPAP works by putting pressure on the alveoli. When you're putting pressure down from the mouth into the bronchioles, into the alveoli, that air pressure is pushing water out of the alveoli, allowing the alveoli to work as intended, and the patient can breathe again. So that's how continuous positive airway pressure works. I showed you a video a couple of weeks ago about somebody putting on a CPAP for the respiratory emergencies. We'll show you a little more detail. And then I know that your skills instructor has a CPAP machine. Hopefully they'll get a chance to pull it out and demonstrate the CPAP machine on like a live volunteer. It's not a painful experience. You just feel a little air pressure. Everything I just mentioned is here, because this is the normal way blood's supposed to travel around the body. And then now take all the arrows and make them go in the opposite direction, and that's what congestive heart failure does to the body. By the way, in order to get to the superior vena cava, blood from the head has to travel down the jugular veins. So jugular vein distension, remember that phrase, jugular vein distension, is one of the signs of congestive heart failure, because blood is backing up into the jugular veins from the vena cava. And here's a couple of videos on what JVD really looks like, at least textbook examples of JVD. Here's the question in the sample under like S. Other signs and symptoms: how many pillows do you sleep on at night? Do your legs swell more at the different times of the day? Which times of the day? See, here it's an open-ended question, because you ask them, you don't say, are your legs swollen more in the day, in the morning or in the evening? Because that's like a yes or no question, single word answer question. So this one, you're not actually giving them a choice of answers to pick from. You're forcing the patient to tell you in essay form, open-ended, when is the leg swollen worst? So that's an open-ended question. So pitting versus non-pitting, and here's like pictures of pitting edema, and swelling in the feet from congestive heart failure tends to form a pit. Non-pitting is like leg swelling from other causes, typically If you see swollen feet or ankles, mention it and then specify whether it's pitting or non-pitting. The doctor will appreciate it. So typical scenario, you're called in the middle of the night. So if you're doing the night shift, you tend to get patients like this. Although some people sleep during the day, so a day shift ENT might get this. You're called for a difficult breather. Patient is bariatric, which is the current term for anybody who's obese. This is the politically correct term, the medically and New York State approved term for somebody who is obese. You find the patient in tripod position on their bed, extreme labor breathing, blood pressures through the roof, off the charts, and then they tell you they have a history of hypertension. But then, interestingly, they stopped taking their medication, so it's spiking their blood pressure now. Whether it's financial reasons or they can't stand the side effects, whatever the reason is, they stopped taking it. Some other things to know about with your cardiac patient. So like I said before, people who've had a previous myocardial infarction are more likely to have a second one. Well, what if you're called for the second one? And so then it's good to find out in their history if they've had a previous myocardial infarction. But you don't have to be specific like that. Just ask, do you have any past medical history, which is the P of the SAMPLE. Remember that? So keep it open-ended. Do you have any past medical history? And then they may say that they had a CABG. And this is what they mean. Coronary artery bypass graft. And what the doctors did whenever this happened, was it a year ago, 2 years ago, was they took a vein, typically from a leg, and created a bypass. So like a highway bypass, right? Continuing the analogy of congestion, traffic congestion. So they've identified a problem area in a coronary artery. So they attached the vein upstream and then routed the blood downstream past the obstruction. And so hopefully that should help. It doesn't fix it. Like the patient still has to get their life back in gear, get in order, but at least that current complaint is dealt with. Angioplasty angio is another term for blood vessel, artery mainly, and then plasty is change, like plastic, your plastic bottle. It's called plastic because that material is easy to change. You take fossil fuel, hydrocarbon, and then you treat it in a certain way, and you have this material that you can then mold and shape into any shape you want for the consumer goods industry. So that's why they call it plastic. So here, artery change, and this is, in this context, is some kind of treatment to change the condition of the problem artery. So intervention is when it's just a different term. The differences between PCE and PCI are beyond the scope of this class. But anyway, the idea is that a surgeon works with, a cardiac surgeon works with a radiologist, or sometimes it's the same person, called an interventional radiologist. They use x-rays to see what they're doing, and then they insert a tube up the patient's femoral artery, snake it up and over the aorta into a coronary artery, and then using the x-ray machine as a screen of where they are, they actually fix it. They fix that artery. Usually they put a balloon to expand it. Sometimes and then they take the balloon out. Sometimes they put in a stent, which is like a mesh. So the balloon will expand that problem artery out, and then the stent will be left in place to keep that section nice and wide for the patient's needs. Now we have this foreign object in the body. What's to stop the body from rejecting it? What's to stop antibodies from attacking it? What's to stop platelets from clotting around it? And the answer is medications. So people with cardiac conditions, with cardiac intervention, they often are put on like antiplatelet or blood thinners, like actual blood thinners, which means people with cardiac histories, if they have a trauma, then they may not have bleeding as under control as ordinary people do. People with a past history of cardiac conditions, and then they have like a cut, assault, car accident, they have a higher chance of severe bleeding, and this bleeding does not stop like you expect it to do. So be aware of that. The other situation is antibody reaction. The response to that is to suppress their immune system, to stop their immune system from attacking these implanted medical devices. They make the immune system just not respond to anything. The patients in this situation are often immunocompromised, meaning they don't fight off infection as well as they're supposed to. Pacemakers, like the sinoatrial node is the pacemaker of the heart, and if that's not working, they may have to have an artificial pacemaker put in there. It's usually planted in the left upper chest, so that if they need the AED, and people with heart conditions are higher risk of needing an AED, then you can put the AED pads in the right upper chest where it's supposed to go, and the pacemaker doesn't get in the way. Sometimes the patient walks around with their own defibrillator, with their own implanted defibrillator. So it's not AED, automated external defibrillator. It's IED, implanted. It's an implanted defibrillator. And do they get a massive shock like an AED gives? No, because this time the surgeons position the electrode right on the heart. So the electrical charge doesn't have to go through hair and skin and bone and muscle. It's delivered right to the heart, which means the charge can be small. So it still probably is, it probably still hurts like a son of a bitch, but it's not going to shock the entire body. Sometimes while the patient is waiting for heart surgery, they walk around with a AED vest. So it's an AED, automated external defibrillator, but the pads are on the skin, but then the rest of the equipment is carried around in a vest, including the battery and all that stuff. And then if their heart suddenly goes into VFib or VTAC, it's going to shock him. What should you do? Well, if you see somebody wearing a vest with wires coming from them to their chest, and it suddenly a voice says, "Stand clear," shocking, what do you do? If I was you, I would stand clear, because this person's about to get shocked. Is this going to cause PTSD in this patient? There's like random times of the day they suddenly get a electrical shock, like being tased. I'd expect they would. I can't imagine this is going to have any kind. I can't imagine it not causing psychological effects on this patient. They would only do this though because they're trying to keep the patient alive, and for some reason they just cannot have surgery today. So they're sent home with a defibrillator vest. Patients with an LVAD, left ventricular assist device, have a machine helping them pump blood, because the heart is they're so weak that they can't live without assistance. So LVAD, left ventricular assist device, there's a tube attached to the left ventricle. It goes to a propeller in the body, and then goes back in another tube to the aorta. So the pump helps push blood from the left ventricle into the aorta so that adequate blood flow and perfusion is provided to the body. Wires come out of the body into a holster for like a control controller device, plus backup batteries, because this is a propeller, right? What happens if you auscultate this? Will you hear heartbeat? Well, it's a propeller, right? So at least in the older models, you auscultated it, you would not hear a heartbeat. Instead, you would hear oh wait, I have a propeller right here. I have a fan right here. That's a propeller. Just trying to. It's an old fan though. While we are waiting for that fan to cycle up, you're going to hear what sounds like a propeller, like a submarine propeller in some submarine movie. And so what do you do then? Well, you should recognize this patient may have an LVAD. What if you try to get a blood pressure on the arm of somebody with an LVAD, with an older LVAD? Will you be able to get a systolic or a diastolic? Because remember, the blood pressure is all about the heartbeat, and this person, it does not have a heartbeat. So what do? Well, you put on the PCR, UTO, BP, secondary to patient is on an LVAD. What about pulse? Because you can't feel a pulse. It's instead of lub-dub, there's just a steady stream of blood going through the radial artery. Again, you say heart rate, UTO, unable to obtain, secondary to LVAD. While the patient is unresponsive and you check the carotid pulse, and I just said you won't feel a pulse, should you do compressions? Because this patient has this delicate equipment coming out of the heart into the aorta. What happens if you did compressions on this machinery? Would you help it or would you damage it? Would you force the tubes out of position as you're doing compressions? So let's go see what New York State says. LVAD, ventricular. It's usually, it's at the bottom of the protocol. Let's go backwards. Ventricular assist device. Perform CPR only when there are no signs of flow or perfusion. How do you know there are signs of flow or perfusion if there's no heartbeat? Check skin, color, temperature, condition. If there is adequate flow, perfusion, then the skin should be pink, warm, and dry. I keep saying older models. What's really happening, because I'm expecting that newer models, because when was this slide made? 2016. You have the 13th edition, so it goes all the way back to 2016. It's now like 9 years later. There's a likelihood that newer models do have a pump so that it creates a pulse and all of this. Oh, here's my fan. My fan finally decided to power up. Bring it close to the microphone. That's nice. Never mind. Can you hear that? So this may be what you're hearing when you auscultate the heart. Not lub-dub, but this thing. Right. I'm going to turn it off now because it's winter's coming. Where were we? Oh yeah, so you hear a hum, and it's saying, look, if there's no sign of adequate perfusion because the skin is pink, pale, cold, clammy, patient is unresponsive, then yes, do CPR, even at the risk of damaging the LVAD. Oh, how do you know they have an LVAD? Because they have tubes coming out of their body going to this electronic box and it says LVAD on it. Hopefully they have friends or family there to tell you, oh my God, this guy has an LVAD or ventricular assist device. Once you have a friend or family there who knows about this device, the best thing you can do is ask them what should you do? Because especially family members, they have been given clear and strict instructions on what to do in case of these situations, and it may not even be a surprise. After all, they have a sick heart. That's why they have the VAD. And so they are been told, like, on this situation, do this. If they're unresponsive, do this. Go to this hospital instead of that hospital. They know what to do. Ask them, what do you want us to do? They are the subject matter experts here. You didn't. The most training you got on an LVAD was the 10 minutes I spent talking to you right now, and will never address this again in the EMT program. So you're not the expert. They are. They will tell you what you should do. I mentioned hospital because sometimes these assist devices, they're not standardized yet. They're definitely not off-the-shelf consumer items. They were often constructed on site in the hospital, and if you show up at another hospital with this, they may have no idea what to do. They don't know where to plug it in. They don't have the software to interface with the controller. They have no idea what to do. So despite that the original hospital that put this in is an extra hour away, it may be better to go to that hospital anyway. Tell the dispatcher what's going on. They will know. You tell them that this ventricular assist device is a one-of-a-kind only model put in by this hospital that's in White Plains or Atlantic City, New Jersey, or Nassau County Hospital in Nassau County, and here you are in Manhattan. And the dispatcher will let you know, okay, you should go to that hospital, because that's the only hospital that knows what to do with this equipment to keep the patient alive. This is New York State. So now let's go to New York City. Because New York City may have something they say about ventricular assist devices. So table of contents. Let's go to the bottom of the protocol. Okay, so here. Where's the CPR? I don't know how New York City EMTs are going to remember all this when they could theoretically go through the entire their career and never run into one. So it could be like 10 years from now, you finally run into one, and all you can do really is Google for the protocol, download it, and then search for this page, which happens to be page 47 for now, and then see. So here it says perform CPR only when there are no signs of flow or perfusion. That's what the New York State says. And there's no evidence of pump function, such as no motor hum. This one is from 2024, was the last update. The New York State protocol is from July 2025. So okay, I guess according to the New York State and New York City, there is no modern LVAD that does generate a pulse. Instead, they still just do the humming, the propeller hum. Okay, so that makes sense. We may be worried that compressions will damage the LVAD, but look, this guy's dead. How much worse can you make it if he's already dead? So if there's no sign of perfusion, there's no sign of pump function, then give it a try, because that's like, what else can you do? At least there's a small chance that the compressions will help, so go ahead and do the compressions, but only if unresponsive, no sign of perfusion, and the machine is clearly not working. I've been talking for 3 hours straight, pausing only to take cough drops and sips of tea. and we're only on slide 69, and there's 135 slides. So how much longer is this lecture going to last? And the answer is only about a minute longer, because the last section is cardiac arrest CPR, and you guys are already now experts on CPR, right? You are eligible for the American Heart Association CPR card. You passed the CPR practical skills exam. You passed the CPR written exam, and these CPR slides are again from 2016. So it's not like these supersede your current AHA 2020 standard. The 2025 is coming out this month, end of this month, so it does not apply to you. So no, we're not going to go through all these slides because it's just repeating what you were supposed to have known already. That does not relieve you or excuse you from not knowing this information. You are still expected to know this information. Questions on CPR, proper compressions, handling of a cardiac arrest will show up on quizzes, on exams, on the final exam, and definitely on the state exam. So you are still expected to know this, because after all, as an EMT, you could end up at a real cardiac arrest. So always review this information. I'm just not going to use up your time this evening in this video rehashing information you're supposed to know already. So we're skipping through all of these slides, and we come to the chapter review, which is the end of the lecture. So thank you for your patience. I hope you had a lovely evening, and I hope you study hard and learn well, and I will see you next time in lecture.